My name is Edgardo Landere from Venezuela, Venezuelan Central University. I'd like to start by welcoming you all to this virtual seminar for universal and free access to vaccines that's co-organized by the Global Dialogue on Systemic Change and the Global Tapestry for Alternatives, as part of a joint effort to contribute to bring together struggles, movements, and networks from different parts of the world to debate and to work together in search for alternatives to the capitalist order. Today, we will deal with the most urgent issue of the present, the COVID pandemic, and the extremely unequal access to vaccines in countries in different parts of the world, as well as significant class and racial inequalities in access to vaccines. We start with the assumption that unless there is universal free access to COVID vaccines, there's no way for the world to overcome the pandemic. This requires, among other things, the massive production of generic vaccines at accessible prices, something that is currently blocked by big pharma, owners of the intellectual property rights over most of these vaccines, as well as the governments of the United States, the European Union, Japan, Russia, and China. This discussion on the pandemic is, for us, only the beginning. There are multiple dimensions that we cannot address today. There are many groups holding discussions and pursuing struggles and research on the issue. We intend to inform about these different initiatives in our website, and we'll probably organize further events. We have an hour and a half for the seminar, so we have severe time limitations. We do not have time for individual introductions of all the participants. So we would encourage each of you to write your name, organization, and email in the Zoom chat. We will also not have time for an open debate. More than 100 people have registered. Speakers will take 8, max 10 minutes each to make the presentations. That will cover the first hour. So we would like to request that your questions and comments be made in the Zoom chat so that it can be incorporated into the conversation and the panelists can respond to your questions. We are pleased to have the participation of 5 distinguished expert activists from 5 different continents who are deeply involved in the struggle for the democratization of access to COVID vaccines. In the order of the presentations, we have Fatima Hassan from South Africa, former lawyer on human rights, founder and head of Health Justice in South Africa. Vittorio Agneletto from Italy, medical doctor, active in the European campaign for the right to care, no profit from the pandemic, host of 32.2, a radio broadcast on health issues, and the author of a book, Senza Respiro, Breathless, on the health catastrophe of northern Italy during the first wave of the COVID pandemic. Jorge Bermudez from Brazil, researcher at the Osvaldo Cruz Foundation, Fiocruz, the key institution working on vaccines in Brazil. He has been closely following the debate on the vaccine waiver at the World Trade Organization. Is the most active network of Brazil activists on this issue. Leena Madhavanai, India, head of the Doctors Without Borders Access Campaign, actively engaged in the Access Campaign. Amir Kadir from Canada, medical doctor, specialized in infectious diseases, former member of the Quebec National Assembly, represented Quebec Solidaire. All presenters will be mainly in English. There will be simultaneous translation into French and Spanish. There's also English translation. Please select your preferred language in the Zoom language option. So I'll give the floor directly to Fatima.
Thank you, Edgardo and Adam and all the fellow panelists. Good evening from Cape Town, South Africa. So I just want to maybe make about 8 points. The first is that obviously we're in a deep crisis as a global community because global population immunity just seems very far off now. Some indications are looking at 2023 or 2024. And this is what we've basically defined as a vaccine apartheid, where some of the richer nations have ample supplies of vaccines and some of us in the global, or many of us in the global south don't actually have it. And I think what's quite positive in the last few weeks is that a number of leaders, including at the WHO and UN level, including the new DG of the WTO, has actually called this out and sort of referring to it as a moral catastrophe as well. And I think that that's quite significant and important. I mean, you all know that South Africa and India are leading the TRIPS waiver proposal, and that obviously that's being blocked by a handful of very richer nations. And I'll come to some of the reasons why we think that is the case and why the opposition is so forceful, even though this proposal has been, been called for since of October of 2020. But the irony is that while South Africa is pushing for something quite considered quite radical in Geneva, in South Africa, the ruling party has not passed the local laws that would enable easier access to compulsory licensing through the Patents Amendments Act in South Africa, and particularly in relation to the contracts that we're securing with a number of the front-runner vaccine companies. These companies are in the driving seat. Our government has basically given up a lot of power in relation to the deals that they're securing with these companies. And so we regard this as quite a schizophrenic kind of situation where globally in Geneva, our government is walking left, but in South Africa, it's actually talking right. We all know some of the latest data, which indicates that 75% of vaccines have been administered in just about 10 wealthier nation countries, while 130 countries, including in my own, have had very few shots of vaccines administered, or in some countries, even zero. The first supplies from COVAX have actually come to Ghana. We've had to secure urgent study stock of Johnson & Johnson after we took a decision to pause the AstraZeneca rollout. And so what's clear, reminiscent of the work we did with HIV/AIDS, is that trade rules, once again, are dominating whether people live or die and whether people get sick or not. And I mean, the documented evidence of this strain on all of our public health systems is so overwhelming. So the situation that we're in, not just in South Africa, but in the rest of Africa, and I think in many other parts of the world, is that we're still, unfortunately, relying on the voluntary nature of these drug companies and their benevolence, particularly in South Africa, even though we're fighting for the waiver. And that can only go so far in the middle of a pandemic. And I mean, we saw this with HIV/AIDS, that the more you talk about compulsory measures and the more pressure you can put on multinational pharmaceutical companies, it may lead to some opening up of voluntary licenses, but not sufficient. And so we've got a severe crisis of manufacturing scale up, where the capacity and ability of other countries and other companies to be able to assist with remedying the self-created scarcity is not being fully utilized. And that the intellectual property apologists, or people who want to enforce patents even in the middle of a pandemic, are basically using the argument of what we call lack of manufacturing capacity to justify their opposition to the TRIPS waiver and to justify their opposition to broad sharing of vaccine know-how. So if I just talk quickly about the situation in South Africa, there's 5 things that are defining the contract negotiations with these vaccine manufacturers. The first is that there are non-disclosure agreements, and we're seeing that playing out in many other parts of the world. The second is there is absolutely no price transparency. And with manufacturers saying that they will only deal with national government and not private players, they've effectively removed the possibility of price regulation in relation to these vaccine contracts. They're being treated and regarded as state secrets. Not even Parliament is privy to the full details of these various pricing agreements, even with COVAX and even with the AU Vaccine Acquisition Task Team and the different bilaterals that our government is engaging with. There's no transparency on the contractual terms and conditions. And our government has now basically been in a hostage, what I would call a hostage situation, where in order to secure supplies of vaccines, particularly the Johnson & Johnson vaccine, it has had to set up a no-fault compensation scheme. And this is similar to the situation that we believe some of our comrades in Latin America have had to deal with in relation to Pfizer. So our government, in the middle of a pandemic, while it's seeking a waiver, has set up a no-fault compensation scheme to provide immunity and protection to vaccine manufacturers whose vaccines have not yet been registered in our country by our regulator either. I've talked about the need for rapid scale up of manufacturing capacity. And I think the irony here is that we, for example, have a company in South Africa that is one of the front runners in relation to generic ARVs and TB and malaria drugs for sub-Saharan Africa, that's Aspen. They've only received a partial license, not a full manufacturing license, for fill and finish for Johnson & Johnson. The state private bio company or vaccine manufacturer called BioVac has not received a single vaccine either from any of the COVAX participants or any of the other drug companies, even though they were pre-selected for the purposes of COVAX. So it's a real concern about who's in the room, who's not in the room, and how these decisions are being taken. Particularly when the EU had its own supply crisis and all of a sudden Sanofi and Novartis were given licenses, and now in the last 48 hours there seems to be some movement with Merck also being given licenses for some of its own, ordinary competitors. So there's definitely a little, privilege club of who gets in and who doesn't get in. And then finally, I've written about this in Foreign Policy around the vaccine apartheid and what we think is underpinning the really pernicious opposition or pernicious form of opposition and what constitutes vaccine apartheid and vaccine nationalism in our view, and that's the blocking of the TRIPS waiver of a pandemic that we haven't, the scale of which we haven't experienced in more than 100 years. And that we really do believe as activists in the global south, that is a real concern about future pandemics. It's a concern that if we open the window on the relaxation of intellectual property rights and protections in this particular pandemic, that it will be very difficult to close that window and that door. And that is why the opposition, both by the richer nations as well as some of these pharmaceutical companies, is actually so strong and is so vociferous, to the extent that there are actually PR companies that are now operating in our country to try and shift the narrative and to try and protect the reputations of these companies. And that existential crisis means that we are going to have to fight even harder for small concessions like voluntary licenses and for small ways in which we can actually ramp up manufacturing scale up while we still fight for the TRIPS waiver. So I'd like to end there and, just with the warning that while South Africa should be congratulated with India for leading on the TRIPS waiver, there are certainly a set of double standards that are operating here locally. But also in addition to the TRIPS waiver and the opposition related to that, we still have to fight for more voluntary licenses. And then I think what I would call the activist third way, not necessarily the WTO DG's third way, is to actually start asking each of our governments now to make use of compulsory licensing measures. There simply is no time to waste, and I really can't understand why we have to make months longer for the TRIPS waiver to be successful, potentially not successful. In a pandemic, the crisis is significant. I think it's time for compulsory licensing. Thank you.
Thank you very much, Fatima. Thank you for your glowing presentation and as well as sticking to the time. Now our second speaker will be Vittorio.
Thank you.
Yes.
Good evening. Here is evening in Italy. Good evening, everybody. I am Italian, but I must speak English, so there isn't a translation from Italian to other language. So I try to speak English in the best way I am able. All right. The situation in European Union now is this. We have 3 different vaccines. We have Pfizer, Moderna, and AstraZeneca. European Union decide to have only one commercial agreement with every of these three pharmaceutical company, only one agreement for all the 27 European countries. In theory, all these countries should respect this agreement, and nobody should act by himself. The reality is completely different. Now there is a strong competition inside the European Union between different countries. And for example, Germany bought more doses outside the European agreement. But this is only one example. The situation is that now the three big companies are not respecting the commercial agreement. They promised to have a lot of million doses in some inside every different month, but they are not respecting this agreement. And this is a strong problem, also because you know that all these free vaccine must be used twice in the distance of some weeks. So it's very, very difficult to organize everything. A lot of associations and unions and a group of civil society organize an European Citizen Initiative. This is an institutional instrument inside the European Union. We need to have 1 million of signatures below our petition. If we will be able to reach 1 million of signatures, the European Commission had to discuss inside the European Parliament and the European Council our suggestion, our proposal. We have 4 points. The first one is health for all. We all have a right to health in a pandemic. Research and technologies should be shared broadly, fast across the globe. A private company shouldn't have the power to decide who has access to treatments or vaccine and at what price. Patents provide one single company with the monopoly control over essential pharmaceutical products. This limits their availability and increases their cost to those who need them. The second point is the transparency now. Data on production cost, public contribution, and the effectiveness and the safety of vaccine and medicine should be public. Contracts between public authority and pharmaceutical company must be public because until now these agreements are secret, and also the European member of the Parliament can look only some sentences, but nobody can read this agreement. Third point is public money, public control. Taxpayers paid for the research and development of a vaccine and treatment. What has been paid for by the people should remain in people's hands. We cannot allow big pharmaceutical companies to privatize crucial health technologies that have been developed with public research. And the fourth point is no profit on pandemic. A big pharmaceutical company should not profit from this pandemic at the expense of people's health. A collective threat requires solidarity, not private profiteering. Public funds should always come with guarantees on availability and affordability. Big pharma should not be allowed to plunder social security system. We have some very concrete objectives. The first one is support the moratorium suggestion of India and South Africa. You know that until now, European Commission and our government are against the India's and South Africa suggestion. We want to be able to change their idea. The second, our aims is to obtain mandatory licenses. We ask our government to decide to use mandatory licenses, and we ask to European Commission not to stop this decision, because, you know, until now, European Commission was always against mandatory license. And the European Commission in the some years ago put inside the trade international agreement with a country outside the European Union a point against the use of mandatory license. These are very, very important aims for us. Our petition, the name is Right to Cool, No Profit on a Pandemic. We reach more or less until now 100,000 signatures, and we must arrive to 1 million. But the European government are strongly against this proposal. For the future, we support the idea to have in Europe a big public European industry about pharmaceutical products, because until now our destiny is completely in the hands of only few big pharmaceutical companies. The last 2 points is this. The first one is that we try to explain our people that there is not a solution in every part of the world. We, Europe, cannot be sure. We explain that we have only one destiny, because if a lot of parts of the world cannot use the vaccine, is probably that the virus can change, become more aggressive in other parts of the world. And after 1, 2, 3 months, this more aggressive virus will arrive also in Europe. So it's our interest to be able, every people, to use the vaccine. And there is another debate now because European Union try to pay more and more money to Big Pharma to convince Big Pharma to have another private commercial agreement with together. And we say that this is not a solution. This is a commercial agreement, which is another way to big increase the profit for the private industry. It's completely different the solution about mandatory licenses that we are supporting about this. Stop here. Thank you very much.
Thank you very much, Vittorio. Now we go to our third speaker, Jorge Bermudez. And I would ask the speakers to take a look at the chat, because some questions have been posed in the chat directly to pertinent to this discussion, and some specific questions to some of the speakers. So I would suggest that you take a look at the chat as a conversation goes along. So Jorge.
Thank you very much, Edgardo. Good afternoon, bonjour, boa tarde, buenas tardes. Initially, I want to thank Global Dialogue and the Global Tapestry of Alternatives for this meeting organization and for my invitation to be one of the speakers, one of the panelists, making clear that I am not representing any institutional organization here. Currently, I am a researcher and professor at the National School of Public Health of the Oswaldo Cruz Foundation in Rio de Janeiro, Brazil. Last week and this weekend, several papers discussed the joint declaration by WHO and UNICEF, stating that inequality has been raised to a more than critical level with the COVID vaccines. 10 countries have catch 75% of the vaccines, as Fatima already mentioned in her talk, and almost 130 countries are not having hope on availability of vaccines or may have them available maybe in 2022, 2023, or even 2024. That is simply unacceptable, and we are really creating a vaccine apartheid in the world. Today, we see Austria and Denmark teaming with Israel on manufacturing. Victoria has just said that. At the same time, Poland requesting vaccines from China, and Slovakia and Hungary from Russia. So they are attempting to boost vaccine production and vaccination earlier than would be expected. Since the beginning of the pandemic, we consider that vulnerable populations have not been prioritized in the vast majority of our countries. Unemployed, underemployed, homeless people, all have not been supported, and inequality has been more evident even in the rich countries. Access to technologies has been deadlocked between solidarity measures and commercial exploitation of technologies, and the quest for monopolies and high prices by the pharmaceutical industry. So need is being overridden by greed. The proposals of solidarity measures has been present since the beginning of the pandemic, supporting the proposal set initially by Costa Rica and all the discussions within the G7, the G20, WHO, UNAIDS, the United Nations, and that gave rise to several initiatives, the ACT Accelerator, the COVID Technology Access Pool, and the joint movement of WHO with Gavi to set up the COVAX and the COVAX facility that would include access for poor countries. Nevertheless, we consider that a mechanism of advanced market commitments, legally binding agreements subsidizing the purchase of vaccines before their availability, brought most countries, besides their supporting to COVAX, also to withhold bilateral agreements, which undermine solidarity. Recent publications mention that at the same time that the rich countries will be able to vaccinate against COVID during 2021, the group of the poorest 84 countries in the world may have to wait until 2024. That's really unfair, and that really is a vaccine apartheid that we are provoking. On the other hand, countries like Canada, Germany, Chile, Colombia have implemented regulation adjustments to enable them to ensure access to technologies and compulsory licenses, avoiding a cumbersome, delayed process. The assumption of COVID-19 technologies as global public goods would be a way through the pandemic and across intellectual property barriers. But on the other side, when we look at data from the medicines patent pool, they show us that currently we have more than 2,000 patent requests for worldwide for medicines related to COVID-19. So the greed for monopoly and high prices is very clear in the horizon. So this brings us to the waiver from certain provisions of the TRIPS agreement put forward within the WTO Council for TRIPS. Following the initial communication by India and South Africa waiving articles from the TRIPS agreement in relation to prevention, containment, and treatment of COVID, beside the immediate co-sponsoring by Kenya and Eswatini, we need to consider that this may be the difference between life and death to many people. It may be the difference between solidarity or apartheid and exclusion, between health and profits for the industry only. Today, we know that 58 countries have officially co-sponsored the waiver, and 62 countries are strongly supporting. So this means that 2/3 of the 164 members of WTO are claiming for equitable and affordable access to everybody by ramping up manufacturing of technologies, not only vaccines, but including vaccines, supported by civil society organizations all over the world and academic institutions as well. The strongest call from WHO for countries to support the waiver was made last Friday by the Director General. At the same time, we would like to welcome the UN Security Council resolution also talking about expanding access to vaccines in conflict zones and in poor countries. Even though we cannot oppose to the alternative that was tabled yesterday by the new WTO Director General, the so-called third way, we still think that this third way represents maintaining, it's a voluntary license which maintains the supremacy of rich countries. It doesn't expand and allows certain steps, but still making clear that they will continue to enforce intellectual property rules as needed. I have stated several times before that I always think that voluntary measures are good, but they are not enough. They are not comprehensive, and they are industry guided with limited geographic scope decided by the industry, whereas we need population and nation guided initiatives and universal access all over the world, rich or poor countries. So I close my comments considering that the pandemic is an emergency situation that needs to be confronted also with emergency solutions. Rich countries must share knowledge, not only waive IP rights, but also share knowledge and ensure that we have, WHO said that we have 41 manufacturers in developing countries that would potentially be able to manufacture vaccines. So we need to ensure universal access, and we have to support local production, not only in the rich countries, but also in developing countries, and support access to vaccines and access to technologies for the poorest of the poor. So the waiver, on my opinion, must be ensured as a right to health and a right on life for all. Thank you very much.
Thank you very much, Jorge. Everybody has been very respectful of the time limits. We appreciate that. Now we have our fourth speaker, Lina.
So should I say good morning or good afternoon? It's quite late here, so good evening. I just wanted to talk about two very essential things that are very key to access to not just vaccines, but all the medical products that we're looking at for COVID-19. We saw that in Netherlands, for example, the chemicals required for producing the tests were in short supply, and the Netherlands government had to take action to convince Roche to share the technology. We've also seen shortages of PPE. We are seeing stark differences in access. For example, a recent statement on the situation in Palestine versus, Israel, where the Palestinian territory has received very few vaccines. So we are looking at a situation where there is inequity, there is a difference between access between vulnerable populations and other people. Having said that, while intellectual property barriers do not offer, if you address intellectual property barriers, it does not mean that all the barriers to scaling up manufacturing would go away. However, it would open up the avenue for a lot of countries, for the countries who have manufacturing capacity, to start looking at scaling up the medical products that we would require. Even though the vaccine is being rolled out, we will see people get sick, and we need to continue pushing for the treatments that people require. So looking at the stark inequity, looking at the fact that there are countries with some capacity to produce medicines, others vaccines, there's a need to address all barriers that countries would face in scaling up production. Lastly, I would like to highlight that if we had proposed a waiver at the beginning of the AIDS epidemic, so in the beginning of the century, we had 8,000 people dying of AIDS on a daily basis, while the world watched what was happening in places like Asia and Africa and Latin America. At that time, we had to deal with patent barriers country by country. So South Africa, Thailand, Brazil, Ukraine, and so on. It's been a long 20-year battle to fight and challenge intellectual property in each country to open up access to antiretrovirals and subsequently for hepatitis C treatment. What if we had an automatic waiver at that time? We would not have lost millions of people to the AIDS epidemic. So I think we need to learn from that experience, is that we don't need to do this country by country. We don't need to do this drug by drug. We don't need to do this vaccine by vaccine. We need to merge all capacity at this point of time. And I think that is where the South African India proposal to waive of intellectual property barriers plays a role in facilitating that. That's one. Number two is this: till now, what we have seen is a situation where countries are grappling with negotiating with pharma companies. They're waiting their turn at the COVAX facility. But this is for the first time that countries have taken a lead to decide the fate of how they want to respond to the COVID-19 pandemic. And I think this is where India and South Africa are so very important. These are countries who have a transplanted intellectual property system. This was not an intellectual property system that was originally in sync with the development needs or the needs of its people or the technology needs of its people. This was directly transplanted from the UK into its colonies. And they left that intellectual property system to fester and to create problems for millions of people who lived in these countries. India tried to address, has addressed some of these patent barriers, sometimes successfully, sometimes not so successfully. South Africa is now at the domestic level trying to reform its laws. But what we must understand is that the intellectual property system was not a law that was in sync with what people needed. It was transplanted from the UK into the South African Indian system, subsequently Americanized through the WTO TRIPS agreement, and we are left today with the intellectual property system that does not respond to situations like COVID-19 or HIV/AIDS. So I think what is very different about the TRIPS waiver this time around, where the proposal is to waive off all intellectual property enforcement on all medical tools for COVID-19, not just restricted to vaccines, is that it does not repeat the mistakes of the HIV/AIDS epidemic. And we do not have to lose millions of people. And that is why it's important to work together to get the European Commission, to get the United States, to get Australia, Japan, South Korea, and of course the UK itself and Canada to change their minds about opposing or dragging their feet over the proposal. That's all. Thank you.
Thank you very much, Lina. We're certainly adding up more complications and perspectives that will help us advance on this critical issue. Now for our last speaker, Amir. Amir, are you there?
Sorry, do you hear me now?
Yes, perfectly.
Okay. Good afternoon, everybody. I'm talking to you from Montreal. I am a physician, and my presence here is due to the invitation of Pierre Baudet, with the collaboration, of course, of Adam Novak and Mr. Lander, because of our, in Quebec, our experience with a small left-wing party in the name of Québec Solidaire when we began our political presence, our presence in the political scene with a proposal about a public poll of production of pharmaceutical products and biological products, including vaccine, to overcome the problems related by the increasing burden of patented and even generic drug cost for Western countries, including Canada and Quebec, where these costs were just grasping increasing chunk of the financement of the health services. Now, to the extent to which it relates with the discussion we have is that because our proposal for a public poll of pharmaceutical production initially was met with what I think is also a subjective obstacle to the type of actions we have to carry for universal access to vaccines, is to overcome the belief that has been little by little installated in the public opinion that we don't have the capacity to produce drugs or develop vaccines. And this is why I think we have to go back to the roots of the same roots that we used for our proposal, which has gained a lot of attention during all those years, and especially since the beginning of COVID. And the fact is that when we began in 2005 to look into this matter, we looked at the successes by the South African activists to give broader access to antiretroviral drugs, and its corollary or a complementary battle in Brazil. And it sounded resonated very much with our own recollection in the mid 2000s, that back in the 80s and 70s, a small state like the Quebec provincial government had public capacity to produce vaccines. Actually, in the 60s, 70s, and 80s, an public institute under the control of a university setting was producing more than 30 biological products, including all the basic needs of the universal vaccination program for the children, and many more, and also biological products that were in use and great demand in the public sector laboratories. At the end of 80s, with the dogma of the neoliberal privatizations, unfortunately it was privatized, and even a very important drug developed through the research capacities of that institute, which was called Institut Armand Flacquier, which was the third available drug, the 3TC, was soon privatized and then completely delocalized by Shire, a big pharmaceutical company. I'm talking about that because in the 90s, what we have to remind, Brazil was facing an epidemic of great importance that is only second to the epidemic that we see now with the coronavirus. In fact, it was believed that if nothing was done in a matter of 10 years, more than 1 million people in Brazil would be suffering AIDS, and with the great costs of the drugs in those years, in the beginning of 90s for Brazil, was almost $5,000 per patient per year. So Brazil was in the face of an economic catastrophe in order to meet the needs of its population. So the Brazilian government, which was not by any means a left-wing government, in face of this disaster, decided to provide overrule the trade agreements which were imposing intellectual property rights and licensing patent problems. And in a matter of less than 8 months, a team of more than 50 scientists under the supervision of a chemist, a woman, a very prominent chemist, were able to somehow rediscover the 3 basic antiviral drugs. And in a matter of the next few years, they were able, in fact, to produce themselves. Brazil was able to produce 8 of the 12 first antiretroviral drugs available. to go through that process. In fact, as we know, they were facing tremendous opposition by big international pharmaceutical companies. But Brazil had, in 1997, passed a law with an article forcing compulsory licensing after only 3 years for any patented drug, which brought Brazil also to be able in the upcoming years to force the reduction of the cost of many of the anti-retroviral drugs needed to fight for the AIDS pandemic. I'm telling that because it just shows that countries in development, which are not in the realm of the Western countries with all their scientific capacities, have already demonstrated that with a public will, if there is a political will from the government, is able to not only develop the scientific capacities to produce the necessary drugs, but also to adequately address the political battles on the international level, including bringing the issue in the front of the United Nations. Many might recall that in the beginning of the year 2000s, the UN Commission on Human Rights declared that access to HIV drugs must be considered a human rights because it's a matter of the survival of the nations. So I'm alluding to these elements to say that these are experiences on which we can tap now to stress the fact that, considering the threat, the health threat of the COVID pandemic, we have to put in our political demands that access to vaccine must be considered a human rights, as we did for HIV drugs, which were literally killing people in third world countries in an epidemic manner, as it's the case today. And also try to link that to the fact that in Western countries, the whole deployment, rollout of the vaccine and their development was done in the front of eyes of millions of people, than more than any other issue were informed about the process through which we went through this pandemic. So they know that our governments, Western governments, public funds have funneled billions of dollars literally in the research and the development of these vaccines. So there is a link to make to universal public access to vaccines, also to the fact that in the Western countries, there is a thirst for the public to see these issues to come to discussion, that we have paid already to develop these vaccines, and there must be rendered free without profit by international companies, as was mentioned by, I think, our comrade Vittorio Angelotto. So in my opinion, there is also a link to make between the battles to carry for universal access to free vaccines for the populations of third world countries, but in order to make to join those battles, and so that there is not a divide, that Western countries don't evade that responsibility, saying that's a problem for only people in India, in Brazil, or in South Africa, to link that battle to the battle that in Western countries also there is no point for the people to pay twice for vaccines that they have already paid to develop. So stress on reminding our public that we already have in the past manufacturing capacities, that these capacities were just privatized and delocalized, that we have to overcome that subjective misconception that only big pharmaceutical companies are able to do what they do, develop vaccines, show them historical examples, and link the fight for universal access in third world countries for the fact that in the West, the populations should not pay twice for these vaccines. Thank you for your attention.
Thank you very much, Amir. These have been wonderful presentations. They offer many, many highlights, many perspectives that can be extremely useful in this global struggle for universal access to vaccines. Now we go to the second part of our meeting. We have 40 minutes left. I wonder in the first place if one of the speakers would like to address some of the questions that have been posted in the chat. Does anybody want to talk about any particular question in the chat?
May I, Edgardo, address some very, very quickly? I think one of the issues that has been raised by several of the speakers here is the need for transparency. Transparency in all ways. And I remember that in 2019, the most discussed agenda item in the World Health Assembly was the proposal by Italy initially, and then co-hosted by several other countries, of transparency. Transparency in prices, transparency in clinical trials, transparent results of clinical trials, transparency in the difference between cost and price. So I think transparency now is being very acute with the delivery of vaccines, charging one price in one country, another price in another country. And most of these vaccine manufacturers have received funds, much funds before. So they should be delivering these products free of charge. I mean, we may have a fund to try to face that, but they cannot be charging poor countries to have profits, because most of them have been, in the United States, the Warp Speed operation and others have funded lots of things for the US manufacturers, and even for manufacturers from other countries. So I think most of the vaccine manufacturers today should share that knowledge and should not be against the waiver. And the countries are revising their positions also, because it's a matter of justice in the world. It's a matter of if we want to make it universal and free to all the people, to the poor countries that cannot pay, I think we need to have not have a profit on that. So I think transparency is one of the issues that's that was most discussed here. It's very important for all of us.
Thank you, Jorge. Anybody else?
Yeah, I just would like to add a very quick point on the fact that the agreements on vaccine supply and the prices are not easily available, or just not in the public domain, or even available to our governments for scrutiny, our lawmakers for scrutiny. And I think somewhere along the line, when we talk about transparency in the access to treatment movement, we must work with actually the right to information and freedom to information activists, because the kind of expertise, the freedom to information and right to information activists who have been fighting for transparency with governments and making progress on many, many difficult fronts, for example, government contracts, is very, very important. I think working alone as access to treatment and just sort of making a very soft appeal to be more transparent is not a very effective strategy. And therefore, we need to look at strategies in our countries and link, link actually right to freedom to information, right to information activists together to do this. We've done this in the past with other areas of work. Yeah.
Thank you, Lina. There's a question for you. There's a question for you, Vittorio. Somebody wants to know more details on how the process of gathering the signatures for this initiative is going on and who's involved and to what extent this has become a sort of global campaign involving social movements and grassroots organizations, etc. And what do you see as the perspective of getting the 1 million required signatures?
Okay. It's not a normal campaign about some signatures. It's a very formal and institutional instrument. In 2014, the European Commission approved this instrument, and is for the people participation. Is a way, not very simple, but is a way to give the opportunity to the people to say something to the European institution. And the European institution must, not can, must discuss with these people and must discuss the petition that the people present. So we have a time. At the beginning was 1 year. Now are 15 months and probably other 3 months. In this period, we have to put together 1 million signatures. This signature must be in different countries, at the minimum in 8 countries, but inside the European Union. But it is better if are in more than 8 countries. The total must be 1 million. When we will give this signature to the European Commission, the European Commission, first of all, must organize a public meeting with a discussion with our European Committee. We have a European Committee that propose this petition. So the first step is a public discussion between the European Commission and the people who wrote this petition. After, European Commission need, in the month immediately after, had to propose a discussion in the European Parliament and the European Council about our petition. And the European Commission must decide if to present a resolution in our direction, or European Commission can choose to present a solution against our proposal. This solution must be discussed and voted inside the European institution. So I think that it could be very, very important to be able to use this instrument. But this instrument gives to us the opportunity also to organize a political campaign in this month to convince, to bring our government to change their idea. And this campaign is of a public debate on the television, on newspaper. For example, in Italy, we have a national committee to support this campaign. Inside this national committee, there are all the trade unions. There are a lot of Catholic associations. There are the leftist party inside, and we are organized 2 days of a battle about these aims. One, it will be the 11 March in the same day of the TRIPS Council, and another day will be the 7 April with the day for the right to the health of the World Health Organization. So we are organizing a public demonstration where is possible, because now there is a pandemic, so it is not easy. only one thing I would like to say, that we must be able to explain to people how big is the profit of a big pharma. We must explain that, for example, in every, if we read some economic research, we discovered that for the next year, every year, big pharma can take only about vaccine for COVID, only about vaccine, more than 10 billion of dollars every year for the next 4-5 years. And I think we cannot accept this. And we must explain that we are discussing about this a lot of money.
Yes, certainly. We have a question from the audience in relation to how the high cost of the vaccines is explained for the southern countries. Is this because of big pharma? Is it because of the intermediaries, or because of the structural weakness of the health systems in our countries? This is a question for...
Yeah. Happy to answer. I think sorry. Should I go ahead?
Yes, please.
So I think it's a combination of factors that we have to look at, and the fact that, you know, COVAX was set up with the aim of providing first 3% and then 20%, and while countries were waiting, supplies were not coming in, and they signed these bilateral agreements with pharma companies, and they were charged a much higher price. So the prices that you see, that, for example, what India pays or the EU pays, countries like Morocco, Brazil, South Africa paid for the very same vaccine double or triple those costs. So indeed, there's a problem, because these are deals country by country, and then pharma companies have more power to charge a higher price. In some cases, what we see is that some countries are still drawing up their vaccination plans. And also what we see is this, that the countries that had first put in the orders to pharma companies were the ones to first receive the vaccines. And this has sort of, you know, disproportionately created access problems between those who need a vaccination now, healthcare workers, the elderly, while, you know, some high income countries have been successful in even rolling it out in the general population. So while they're reaching 50% or more, for example, in the UK, you see much lower rates and actually none at all in some countries. So I think it's a variety and combination of factors, health systems reacting late, COVAX facility not working in time, and of course, pharma companies charging a higher price.
Thank you, Mina. There's a further question on the issue of, is there a difference between what China and Russia are doing in terms of their vaccine research, production, and public policies in relation to these vaccines, in the way it's been distributed to the rest of the world, whether the public companies in China and Russia, there's both public and private, whether they are more likely to provide free or cheaper vaccines to the poorer countries, or whether there's speculation. There's at least one Chinese vaccine which is very expensive, even more expensive than the Western pharma vaccine. So I'd like to have some comments on all of you in relation to this issue, because it's really critical, because this is like the geopolitics of the vaccine. So who'd like to go first? You want to say something, Lina?
So I think it's a mistake to ignore the from a technology point of view, China and Russia are right there. They have the capacity to develop these vaccines. And indeed, countries are adopting Sputnik and, of course, the Chinese vaccine. And I think there's a very good article by Achal Prabhala and Yo Kling from the Third World Network highlighting that we really need to be, as People's Vaccine and other activist forums, to be talking about the Chinese and the Russian vaccine. There's no doubt there's a need to talk about the issues that arise with the Russian and Chinese vaccine. They are definitely alternatives that countries are resorting to, so you cannot ignore them. That's one. And number two, I would like to say is this, that I think what, the issue fundamentally is that the data on the Chinese and the Russian vaccine is flowing, for example, from the from the Brazilian FDA and some other FDA. So we need to be paying attention to the data that is now becoming available on these two vaccines. And any access to vaccine debate needs to encompass the Chinese and the Russian vaccine, and perhaps in the future, an Indian vaccine as well. They'll all play a role, undoubtedly. The same issues may come up, which is high prices and transparency. However, there's no reason that countries who are already rolling it out, we should not learn from the experiences.
Any other comment on this question? What has been the experience in Brazil and in South Africa in relation to the Chinese or the Russian vaccines? Jorge?
Can you repeat the question, Edgardo? You were talking about the Chinese vaccine in South Africa?
No, I'm wondering, both in the case of Brazil and South Africa, what has been the experience with the Chinese or Russian, if any vaccines have arrived, under what conditions?
On our production. Well, Brazil has two main agreements with vaccine manufacturers, Fiocruz with AstraZeneca and Instituto Butantan with Sinovac. So both have received initially final presentation of those and have been distributed. And now both have also received the APIs for manufacturing here, and both are receiving the total technology transfer to begin total manufacturing here. And the expectation that we have in Brazil, in both institutions working together, is that to the end of this year, we'll have about 240 million doses being produced by both institutions. That's a Chinese vaccine, CoronaVac, and the AstraZeneca vaccine. And we have also already begun to roll out the vaccination program in Brazil. Initially, the frontline health workers that are dealing with COVID. After that, the elder people, they are coming back from 99 years. Now we are vaccinating 87, 88 years old, and we're vaccinating 86, 85, 84, 83, 82, 1. And health professionals more than 60 years old as well. And then it will go to other priority groups, as professors, frontline attendants, and other drivers in public transportation. And at the same time, of course, we have increased our capacity of manufacturing diagnosis. So I think that we are dealing with that. The institutions are dealing with that, in spite of the government that during a long time denied that we had a pandemic or a disease. But institutions have managed to go through and make their own arrangements, and we have that. And we also have an agreement being rolled out with a private company in Brazil with the Gamaleya Institute for the Russian vaccine. We'll probably have the Russian vaccine, the AstraZeneca vaccine, we have the Chinese vaccine, one of them, the CoronaVac, and probably COVAX also, as Brazil has adhered to COVAX, we'll be receiving COVAX vaccines. We don't know which ones will that be? So, and we are hoping also that the Cuban vaccine, the Soberana 2, that's beginning the clinical phase 3 trials, may also be an alternative for Latin American countries. So I think, and we have an agreement also from Argentina and Mexico that have absorbed technology from AstraZeneca and was produced in Argentina and bottling in Mexico. I think we have several initiatives ongoing in Latin America. So we hope to go through. But I think that we need to be concerned with other countries. I mean, we know that we have countries that have a capacity to manufacture. This capacity has to be enforced. It has to be enhanced as well. And that's a role that I think that WHO, together with other UN organizations, has to play. It cannot be a country by alone trying to seek its own capacity building. I think we have to have, as WHO mentioned, 41 manufacturers in developing countries in the world. This has to be very well mapped and very well defined to see what is necessary to scale up this capacity, because this capacity has to be used. But for this capacity to be used, is that we are discussing also why the waiver? Because the waiver can share knowledge, the waiver is absolutely legal. I think that's another issue that we need to discuss. When we talk about the TRIPS agreement, and we say that, of course, countries say no, but TRIPS agreement says we need to have intellectual property to be able to have innovation. That's not really true, because companies now, many companies are not having innovation. They are buying other companies, they're buying startups, and with that they have patent protection on the products that they didn't develop. They didn't have research on that. So they just bought some other startups, other companies, and they want to recover the cost they had buying the companies. So I think we have, that's one of the needs for transparency also. And another thing is that when we talk about TRIPS agreement, we have to consider TRIPS obligations, of course, that all the countries of WTO signed TRIPS obligation, but at the same time, the countries signed the TRIPS flexibilities as well. TRIPS flexibilities are a right for the countries to use. And the Doha Declaration enhanced that right of countries to it was here in the chat. And one of the recommendations, finally, during the year of 2016, we had the UN Secretary General high-level panel on access to medicines that had several recommendations. One recommendation was very clear in intellectual property and TRIPS agreement, that governments and the private sectors must refrain from explicit or implicit threats, practices, tactics, or strategies that undermine the right of WTO members to use the TRIPS flexibilities. And that has been common, because small countries cannot issue compulsory licenses because they are threatened by big companies, because they depend on exportation to big countries or to rich countries. So I think that's another thing that has to be very clear here. We signed the TRIPS obligations, but we also signed the TRIPS flexibilities. And one of the countries that most uses TRIPS flexibilities, not in medicine, but in other areas, is the United States of America. They have in IT and technology, many compulsory licenses being issued every year. So I think that we need to be able to use also TRIPS flexibilities. And the waiver is just a broad use of TRIPS flexibilities. I mean, if we go country by country, the patent law is a national law. So we had to, each country would have to issue a compulsory license on any product that they want. If we waive that by WTO, and 2/3 of WTO members are agreeing with that, I think that's a way to move so that all the countries have the right to explore that and to have those products available for their populations. And at the same time, we have to enhance the the production capacity we have in the world. So I made some comments outside of what you asked, but sorry.
That's fine.
May I say one thing? Okay.
Vittorio?
Yes, only one thing about Russian and Chinese vaccine. I think that this discussion is a part of a strategic geopolitical confrontation in the world. And for me, like a medical doctor, like as a research, is very, very difficult to understand about a lot of news that I can hear, to understand the difference between some health reason and some political reason, because they are mixed and it is very difficult to understand. For example, European Commission until now didn't discuss anything with Russia and China, and said we cannot discuss because Russia and China didn't present their vaccine to EMA, European Medicine Agency. But on the other part, some European country, for example, Hungary, is using Russia vaccine, is already using. And this is outside of the European agreement, but they decide to use this because it's cheaper and because it's easier to book a lot of doses. And in my opinion, it will be very useful if our world activist community was able to discuss about this geopolitical reason and to explain the real health reason on the part and the political reason on the other, because it's not easy to move inside this situation. For example, the same days that South Africa said that AstraZeneca was not very good for South Africa virus, in the same days, some European research and health organization said, no, it's not the truth. Everybody can use AstraZeneca. It said AstraZeneca is okay with all the virus. This was a political words, not the reality. So I think that we could have a very, very important role as an international activist community.
There's a question directed to Amir in relation to Canada. According to a lot of media information that has circulated, Canada is supposed to have bought something like 4 or 5 times the amount of vaccines it would need to vaccinate the whole of its population with the first and the second doses. How can this be explained? Amir?
I think Amir
Edgardo, Amir had to leave to go to his work.
Oh, he's not in. Okay. Well, there's one general question, and then ask you for some closing comments from each of you. How significant is the anti-vaxxer movement in each of your countries, and to what extent has it become an obstacle to this issue of universal access to vaccines? Lina?
I'm going to answer that question. I'm going to answer that question not as MSF, but as a person who works with communities a lot. And what I see is that this discussion about anti-vaccine is not led by community groups. Many of the community groups are very well organized on science. They know the antiretrovirals, they know the hepatitis B vaccine. They are very well aware about, for example, a lot of groups are very well aware about the benefits of the pneumonia vaccine. And I think what we really have to highlight is the community voices. You know, if you look at sex workers in India, they've been demanding the hepatitis B vaccine for over a decade now. And I just would like to highlight that in some sense, the anti-vaccine movement is sort of suppressing the voices of the communities who have long struggled to ask for adult vaccines. Vulnerable communities have been left behind. Drug users, sex workers who would have benefited from the hepatitis B vaccine. Elderly populations. My father got pneumonia and he should have been vaccinated for pneumonia. I have to say this. His lungs are so weak now. So I think community voices are very important. And they end up sort of, taking the attention away from the demands of very vulnerable groups who have highlighting that national immunization programs need to encompass their needs as well. So all I have to say is this, that I work with communities and their voices are very, very important on the access front. I would also like to say this, that communities and patient groups are not behind on science. We know the science on HIV, we know the science on antiretrovirals. It's very important that we share more information on essential vaccines with the communities that we work with and let them make up their minds about what they really want to do. And I think, in short, what we need is a movement from the ground up, which highlights the kind of deaths we've seen or the kind of sickness we've seen due to pneumonia, due to hepatitis B, and the impact, the positive impact the availability of vaccines can have in these communities. I cannot speak for MSF, but as a person who spends so much time in these communities, their voice is constantly overshadowed by that movement, the anti-vaccine movement, which is a shame because they should be, heard constantly. And if countries had set up an adult vaccination program today, we would not be struggling so much to provide the COVID-19 vaccine. For long, we've just ignored the fact that adults are also vulnerable and there needs to be an adult vaccination program in developing countries. So I think I'll just stop here because it sort of hurts, it is hurtful to see, vulnerable communities who've been demanding vaccines, their voice overshadowed in this fashion. Yeah.
Okay, we have a few minutes left. I'd like to ask one last question and ask each of you to make some, if you wish, some closing remarks. The question is this. It seems to be quite obvious that we are in a fight and a struggle against time because of this that has been mentioned, the fact that the more time that goes before there's some sort of herd immunity worldwide, there'll be more mutants, more changes in the virus, and it's likely that it would come back even to countries that have 100% vaccination, if that were the case. It's easy to understand why Big Pharma is opposed to any flexibility in terms of intellectual property rights. But it's really hard to understand why the political systems, why the governments are willing to back Big Pharma in this when they have to know that this represents a serious threat, not for the poor inhabitants of the South, but for their own populations as well. This is so hard to explain. Could you comment on that in your final comments? Who wants to go first? Jorge?
Okay, I think that this debate, Edgardo, comes from many years to now.
Yeah.
I mean, I remember since 2003 with the Commission on Intellectual Property Rights, Innovation, and Public Health, the discussion between innovation and intellectual property was very clear and was very confronting. And this has been repeated all through the years, including during the setting up of a global strategy on public health innovation and intellectual property. That's currently a document that's been adopted and many people are looking forward. And in part, this comes through the Millennium Development Goals and now the Sustainable Development Goals. I mean, the access to health, access to medicines is a debate that's been present all the time. So I think this will continue. But I think that the pharmaceutical industry has always opposed, and some governments already also always have opposed to discuss intellectual property on a more, let's say, public health approach view. And maybe pharmaceutical companies are wanting to maintain the monopoly because this vaccine will not be a one-shot vaccine and then it's over. I mean, maybe we'll have to repeat this every year or every 2 years or periodically, as we are doing with influenza now. With influenza, we are vaccinated every day and the same manufacturers always have this vaccine available. So maybe the great manufacturers are betting that we will continue to have this situation and they will continue to have profits from their vaccines. And
We will continue to depend on them.
Hmm?
We will continue to depend on them.
I didn't understand.
That we will continue to depend on their products.
Yes, we will continue to depend because we are not, we live in a capitalist model and we will continue to depend on that. But I think we have to bring this more to an approach to as a health as a right for all, and access to products, technologies as a right included in health. And this has changed the constitution of many countries. Brazil, Venezuela, other countries have changed their institution and have incorporated the right to health as one of the mandates of the constitution. I think this is one thing that we need to preserve. We need to defend also. We will also be in different ways. We will never reach consensus on that, but we will continue to struggle. And I think we are advancing in some things, we're losing other things. That's normal. I don't think that this will change. But we need to defend our principles. And our principle now is to defend a waiver as a way to expanding the possibility of developing countries also coming into the production of a vaccine for COVID-19 at this moment. But also, we are also building stronger countries and stronger institutions in developing countries. That's important, not only depending on the big pharmaceutical companies. So I think that we're not satisfied only with voluntary agreements. Voluntary agreements are fine, we need them. But we need also to have the compulsory licensing as a right. And this is waiving some TRIPS articles to make it available for everybody. I think this is why we are defending the waiver at the end, and we have many countries defending, civil society defending, academics defending. So I think that's a way forward.
Thank you very much, Jorge. And now some very brief closing statements. First, Victorio.
I want to remember that Big Pharma is one of the most important lenders of the political group in the West. Is one of the most important lenders of all president candidate in USA, but not only. I was for 5 years a member of European Parliament, and I remember very well that every time we have to discuss about some political thing about drugs, there was a strong pharmaceutical lobby inside the parliament, with a lot of message, with the dinners, with the appetites, and so on, to convince a single map to change his idea. So there is a link, a very important link between a big pharma and a lot of political group. in Italy, some important political person, when they finish their political career, they became, they went on the top of some big pharma. So I think the problem is a political problem, only a political problem, and I think that this will be one of the most important problem for the next years in the world. Not one of the important, but I think it's probably the most important problem in the next years.
Thank you, Vittorio. And now, last words by Lina. Do you have anything to say?
It's quite late here, so sorry, I'm just nodding off. I just wanted to say this, that we often forget that, you know, these companies and their profits are linked actually to the governments who are backing them and are very now reluctant to have a reform of the intellectual property system, even if it is for a limited time for COVID-19. And I think these are very entrenched systems, and they're difficult to, you know, convince otherwise the policymakers of these countries otherwise. But I also wanted to say this, that intellectual property systems have historically worked against people of color and people of people in developing countries. And I think the world can no longer sort of, you know, ignore that fact that intellectual property systems have often left all of us behind in terms of not just in the products that are very expensive, but our R&D needs that we really need. And I think this is where I think the intellectual property system is in principle was created for social good, but then has completely lost that goal and has turned into a very abusive, I would say, abusive system that is very entrenched in monopolies, refuses to self-reform, and that's where the activists come in. But in 2021, I doubt anybody can say that we've majorly benefited in Asia or many other countries where people of color, we've seen in the HIV/AIDS epidemic how our comrades passed away. And actually, what should disturb us about intellectual property systems is the lack of debate on these areas of what the intellectual property system does to people of color, what it does to health systems, and most importantly, the refusal to reform. I don't see why system, we've reformed so many institutions in this century to be more transparent, to be more accountable, and why the intellectual property system is not the same, you know. So that's where I would sort of stop and say that, you know, as Doctors Without Borders, we do believe that alternative suppliers for any product are very important. We are seeing a shortage of liposomal amphotericin B now in India. It's an artificial shortage. Why? Because we can't afford to pay the $70 that Gilead and the distributor are demanding from us. So it's an artificial shortage. The drug is available. It's being sold for almost $200 in the Indian market, but we can't give it to our patients with cryptococcal meningitis. So an antifungal which is available to the rich is not available to people living with HIV. And to the governments who need them most. So I think this is the kind of system that the intellectual property system or monopoly system, I would say. Ambisome is not covered by a patent, but nevertheless under monopoly. And monopolies tend to work against people. And our competition commissions and other bodies need to start working better. We just don't have an accountable system to make change the IP system. Yeah.
Thank you very much, Lina. And well, I want to thank all of you for your participation. This has been a very stimulating debate. We have a lot of rich analysis of this complex issue. As Global Dialogue, we will come back to you with a report on this discussion and the proposals that are were presented. This is obviously a very vast issue, a very vast discussion that implies capitalism as such in its whole. And so we will get back in touch with you. We will distribute this report, and figure out how to continue to promote these debates, these articulations, these struggles, in this campaign, in which what's been done in one country has to contribute to what's going on in other countries, because this is obviously a global issue, and it deals with issues of life and death for humanity. So thank you very much, and we'll see you soon, we hope. So long.